Thanks, everyone. I'm excited to show you some interesting stuff, especially because it's highly timely right now with all of the news that is happening around GLP-1s. And I just want to introduce you to an expert and some of the tools that are available for employers, especially who may have employees that are pre-diabetic or diabetic in a type 2 diabetes scenario. Let me introduce to you Madeline Clark of Moose Pharmacy. Madeline, tell us what you're doing there at Moose.
So, like Christy mentioned, my name is Madeline, and I am a clinical community pharmacist. And we are working on a project where we are reviewing our patients' continuous glucose monitors, their logs, essentially. So we are able to, as a pharmacy, connect with their device via their Bluetooth, or if they even use a reader, we just have them bring that into the pharmacy, and we're able to download that data. And then we are able to use that data to look at patterns and trends and really assess where our patient is, how to help manage our patient better, and what we can adjust for therapy if needed.
So, and full transparency, I too joined this program because Joe Moose, one of the owners of Moose Pharmacy, who's my client. So I serve as Moose Pharmacy's employee benefits advisor. And I was meeting with Joe sometime during the late summer after we both went to Chicago and accepted the Health Rosetta's Rosie Award for the Moose Pharmacy Health Plan. So congratulations again to the Moose organization for winning a great honor as having one of the 50 best health plans in America. Well, Joe and I were talking over some things, and I had on a sleeveless top. And so he could see the patch that I was wearing over my Freestyle Libre. I was using the number 2 version at the time. And he said, "Hey, did you know about this program we're doing?" And I said, "Sign me up, man. I want to be a guinea pig in that program because it sounds great." So I'm actually enrolled in a program where Madeline is watching the CGM that I wear, because of this program, I decided to switch over and try out the Freestyle Libre 3, which I want to tell you is incredibly useful as someone who has had type 2 diabetes for, 13 years now. I think I probably had it longer than that, and no one was checking me. I was first diagnosed with diabetes when I was pregnant with my firstborn. And I just don't think it ever really went away after that. But no one was checking me either. So I don't really know how long I had it. But for about the last 13 years, I've been trying to manage it, kind of taking one step forward and 2 steps back. And really the game changer was when I joined the practice of a direct primary care doctor. That was game changer number 1. And then eye opener number 1 was when I started using the Freestyle Libre system. That was a huge eye opener for me. And it was about last summer, a little over a year ago, that I decided to start trying intermittent fasting as a tool. I hadn't been encouraged to do that by anyone but a friend who was also doing it, and I thought, well, might as well. I've tried everything else, right? As a matter of fact, I'm one of those people that tried Ozempic for a while, and I've got my own opinions about it. Some of that we're going to get into during this conversation, but I think that the main message I'm hoping you hear is that these GLP-1s, some people call them semaglutide. I've heard it also pronounced semaglutide. So whatever you call it, these extremely expensive drugs that really are making weight just melt off of employees without them even trying. I think that there's a better, more effective, and less costly way with more data and better guidance from a specialist like Madeline, who, by the way, has a designation called CDE that stands for Certified Diabetes Educator. Madeline, will you tell us what it takes to become a certified diabetes educator?
Yeah, absolutely. So I will just like clarify. So like we're in the process of it, my co-resident and I. So we do have to like be graduated for at least a year. So we're just like in the process of like obtaining all of our continuing education programs. So we're in the process of becoming them. But essentially it is just we have to have a certain number of continuing education credits that kind of varies by state, but we are able to look more at trends and patterns in patients. We are trained to like look at the therapies a little bit differently and just really help patients on an individual basis instead of just saying like, oh, let's just like throw all this out. And it just like really helps looking at a patient individualistically and not just trying something that may work for everybody. So it's just a little bit more specialized for them.
Excellent. And did I hear you say there's a certain number of clinical hours you have to log in before you're eligible?
Yes, and so that's part of the reason Riley and I, my co-resident, we're still working on it because you have to be graduated a certain amount of time and you have to have so many like clinical hours dedicated towards diabetes. So we are in the process of that. And then to keep up the certification after you obtain it, you have to have I don't know the exact number for each state, but you have to have a certain number of continuing education credits when you renew your license each year to continue that certification as well.
So suffice it to say, there's not a more specific expert on the disease of diabetes than someone who bears the CDE designation. So let's just put that out there.
Yes, it's a lot of training.
Right. Lots and lots of specific training. So that's really important. And I'll say one more thing about the fact that local independent community pharmacies, where you're currently doing an internship, this is a game changer for employers. I realize when you create health plans and you design them and you pick certain vendor relationships, sometimes you could get convinced that opening up the entire pharmacy network to an employee is a good thing to do, so that they can have any pharmacy in the country at their that they can walk into and receive prescriptions from. Well, the reality of that choice is that there are good uses for that, but there are more often than not, that's going to create adverse outcomes and misaligned incentives. And we can talk about that along the way. But the point of this video is to go into the reporting features for part of the Freestyle Libre system is called Libre View. And that's where the patients who wear these continuous glucose monitor sensors can share that data with their medical professional, their primary care physician or provider, and plus, someone with this high level expertise like a certified diabetes educator. So I think you can share your screen now, Madeline, and if you'll open up what you want to show. Yeah. And go through some of the interesting things you can see on your side of Libre View. I think that is super interesting.
Yeah, absolutely. Thank you for letting me share this. So this first one, let me get to full screen on that one. So this one is a patient that we have been working with in this program that Christy was talking about. So this was when he first started in the program. And one of the cool features with our continuous glucose monitor like profiles is that patients can log on their apps when they eat, when they work out, when they inject insulin, if they do that, when they take other medications. So, there's a lot of data that we can collect from this app. And so this was like right when he got it. And we noticed, if you'll notice on like the bottom one, he goes high about like 8 a.m. and he had not eaten yet. And so that's something that we call the dawn phenomenon. And he was really upset about it. He's like, I'm really trying really hard. I'm eating a lot better than I have been. Like I am walking, like what can we do? So we worked with him on some lifestyle strategies. And then this was just like the last couple of days. There's like a very minor little peak around 7 a.m. Both days, but much better than he was when he started. So just like being able to implement those lifestyle changes and timing of medications. But I like this example because he is one of my only ones that really uses the logging feature to its capabilities, which I think is like really cool that, we can see. So, another disclosure, my dad is doing this program and we were trying to figure out what he had been eating because he was working, he was out of the country working. And so he had like these weird spikes and I was like, oh my gosh, like what was it that you were eating? He was like, oh, I forgot. Like, I don't even remember now. And so that is like one of the goals I'm working with him on is like to start logging so we can see exactly what is raising your blood sugar. Because if it's something that, you don't eat regularly, it's just like okay to you, maybe you'll opt for something different the next time if it's not even like your fave treat. And then if it is your fave treat, maybe, like, okay, I'm not going to eat, the whole thing. I'm going to say eat half today and half tomorrow. So, really just utilizing this data to help patients, empower them to make their like better lifestyle changes that work for them. And then the second one that I will show you, let me stop my share and then pull it back up, is a patient that he is on 2 expensive brand name medications. One is a GLP-1, so one of like the weight loss ones that we had been talking about earlier. And this is just his last few days. And you can see that a lot of red, and we don't really love the reds because that means that our patients are going below 70 mgs per deciliter of in their blood sugar. So that means that they're dropping really low. They could have a hypoglycemic event. They could essentially like pass out. And so he is still on the 2 brand name medications. This was happening prior, and his doctor decided to lower him off of metformin, which, is one of our go-tos, much cheaper medications that we use for diabetes, but he chose to take him off of this one. And so my co-resident and I, our new proposal is that he really needs to come off at least one of those brand name medications, preferably probably the GLP-1, because we do believe that that is significantly impacting his sugars for him to go low. And so I think my thing with this is, number one, I think we need to optimize our medication therapy and look at what is the most effective for each individual patient. But we probably won't be able to recognize that unless the patient has a GLP or a CGM on. And so in my personal opinion, I think if you are on a GLP-1, you would be very beneficial to have a CGM on to see what it is doing to your sugars. Because this happens a lot, like overnight. He is not always aware when this happens. Sometimes he wakes up with some symptoms, but not always. And so just really making sure that like we are monitoring our patients to the best of our abilities. And then when we see things like this happening, we can look at our, medication therapies and how we want to optimize that for each individual patient. So I just thought that we were, reviewing our patients yesterday, and I saw this and I was like, oh my gosh, like I called the wife and I was like, okay, like, is he okay? Like, what do you need from us? Like making sure they have glucose tabs and all those kinds of things. But really, like, how can we better work with his provider to say, okay, I think one of these needs to come off. We can work to add metformin back on eventually, but like I want to make sure he's not dropping into the 40s overnight. So that one was pretty eye-opening for me, that these supposedly like great weight loss ones, and they are, there may be like there's a time and a place, and we need to like be monitoring our patients to the best of our abilities with that.
Sorry about the dog there in the background. So suffice it to say that wide fluctuation in blood sugars really causes you to have to use medication more than you really need it. And tinkering with the medication after maybe you've been preliminarily prescribed something that you probably didn't need really in the first place, that's a much more expensive endeavor than just slowly trying more organic methods and then graduating up to, some of these newer, more expensive GLP-1 remedies. I have two questions for you. Is there any data yet or research to suggest what a person's A1C ought to be before before the prescribing graduates all the way up to these most expensive drugs? I mean, I realize type 2 diabetes kind of has a low, medium, high, or sort of threshold. So talk a little bit about that, if you know.
That is a great question. And I don't think that there are guidelines out for that yet. At least I have not seen any that I have come across. I think that they're most likely we will start seeing those, like maybe suggestions, but also we have to consider too that there's also like one of those like semaglutides for specifically weight loss. So not even if a patient has a diagnosis of diabetes. So a patient could get this with an A1C less than 6. So it's not necessarily like our patients that have A1Cs at 14-15% that really could use like a pretty drastic drop in their A1C to help control their blood sugar. We're seeing it started in patients that do not have necessarily a diabetes diagnosis that are getting this.
Good point. And as a consultant, I have certainly heard of organizations who are trying to say, look, can we limit our formulary so that employees who are struggling with obesity can't just opt for these expensive drugs, that they actually need to try, going to the gym and changing their diet, and maybe try a CGM first with a person who's trained on how to look at how diet affects their blood sugars, and other methodologies to lose weight rather than just getting on Ozempic or Wegovy, or what's the other one, Mounjaro. And I just read an article yesterday in Medscape that says this trend is not going anywhere anytime soon. The gravy train has been, the word is out that this is the cash cow that the drug industry has been looking for all along, and it's going to come at the expense of employer bottom lines. The EBITDA that organizations, corporate organizations, are going to have to increase in order to fund this trend is magnificent. And so I think that if you ask your consultant and they tell you, well, I'm sorry, you can't custom design your formulary, you probably need a new consultant. So, okay, well, will you pull up mine? I'm transparent enough that I can use myself as a guinea pig here. Now, full disclosure, yesterday, you're going to see a break in my data because my CGM, one of my sensors I was dispensed for this month, fell off last night at the gym.
Oh no.
So I had to toss it. That's just a good personal recommendation to all you folks out there. If you're going to use one of these, go the extra step and buy some of these adhesive patches, that you wear over top of it to protect it from sweat and, bathing and stuff like that. So,
so this is what the portal looks like on our end once somebody connects to our clinic, and then we are able to see just like the new glucose reports. It just takes a second to load. There's just so much data.
And you know what? It's important data. This is the kind of intricate detail that really needs to be evaluated just to make sure everyone is getting the right kind of care for this disease. Diabetes is highly complicated, and it doesn't affect everyone the same way. even the food that I eat as opposed to the food that another type 2 diabetic would eat affects us all differently. So, hey, this is a glimpse into the whole concept of personalized medicine, right? I mean, that's the buzzword in the industry is personalized medicine. Well, this is one way you can latch on to that concept is by being partnered up with a local independent pharmacy in your town that participates in a program like this.
Yeah, so this is just like we call it, like it's our ambulatory glucose profile. So it's the term for it. And it shows us just like the averages for this is just last 14 days. So for the Freestyle Libre, the sensors last 14 days. The Dexcom is another one that we have some of our patients on, and we can look at that through the Dexcom Clarity. So you just like set your ranges of like how far out you want to look at, but this usually like will pull like just like the last couple weeks. It does show you like a predicted A1C, which is like the glucose management indicator. And then glucose variability is one that we look at. So that is like what we want to see, like, you know, when they eat or when they don't eat, like how drastic do the sugars rise or fall. And so then we have like a map where the dark blue is, you know, the average for the last 2 weeks. And then as it gets lighter, those are just like kind of like the, you know, the side of the bell curve, I guess, like not as high or like not as much of the readings are there, but they had gotten there. And then we see like a little glimpse of daily glucose profiles. So that's just like the first page, which we can honestly get a lot of data from, but then going even further from that, also something that I, you know, appreciate on this too is like considerations for the clinician. So this obviously like analyzes the data and looks at it. And so it may be something that like we didn't even recognize just like by glancing at it. And so this one says, you know, medicate, like what type of therapies should we look at? Like it's not going to tell us that, like that's where our clinical judgment is going to come in. But this is cool that our side of the portal does have some of these like recommendations like that. Then we get like the glucose pattern, which is more like, I guess, detailed in this. You can kind of see like the actual dots where the readings are. And then we get a monthly summary. So this we can kind of see like on average, what was that patient's daily average for the whole entire day. So fasting, non-fasting, whole day average. And then we can kind of look, a lot of my patients will look, and on Saturdays and Sundays, that is when they are like the absolute highest. And then Monday morning, they're back to their normal. But it's just like over the weekend, they, you know, eat what they want. So that always like makes me giggle when I like see those. But then we like get the daily logs like I was showing you earlier, and that's where we can really see like almost not quite minute by minute, but like pretty much hour by hour, like, okay, I ate something at 9 o'clock and by 10 o'clock my sugars were, you know, 150, 200, 250. And so it really helps us
Hey, I want to say something about let's look at that October 22nd graph.
Yeah.
So that is a really good portrayal of what I started experiencing when I was when I'm doing pretty good on my intermittent fasting. So like I said, with Ozempic, I think that one of the ways it helps people lose weight is because it causes this mildly nauseous state. It's one of those feelings that you get when you just don't feel like eating, right? And you might put a few bites in your mouth and then you push the plate away from you because you're like, I just don't want any more. And part of the mechanism is that it just makes you feel just a little bit nauseous. The marketing materials around Ozempic calls it the feeling of fullness. But for me, and I've heard this from plenty of other people, it's that feeling of if I take one more bite, I'm going to be sick. And so in the first couple of days after you inject it, you really have that feeling a lot for about the first 3 days. And so just think about the kind of weight you might lose if you were fasting for a 3-day fast. You'd lose some weight, no doubt about it. So when I adopted this intermittent fasting, I told my friend who recommended it to me, I can't do that because I'll dip way too low, and then, I'll just be on this roller coaster. And he said, kindly and nurturingly, he said, I just think you're wrong. And so when I said, okay, I'm going to try it and prove him wrong, but he wasn't wrong. So like that October 22nd is a really good representation. I start out in the morning with, coffee with some cream in it, and it might take me just a little bit high. Probably that day I might have eaten just a little something, but then it calms right down, and throughout the rest of the day until around 3 o'clock, 3, 4, something like that, which is usually when I have a little bit of a snack before I go to the gym. But all day long during my fasting hours, it's just steady Eddie, right? It's just very flat.
Yeah, that is
And
great.
I think that's an important dynamic to point out, that there are plenty of other, what we'll call organic methods for trying to manage blood sugars, but without drugs that cost thousands of dollars a month. So
Yeah, I think they're all tools in our toolbox, right? And each situation needs unique tools to fix it and work on it. And so not every patient should be treated the same. And I really think like having a CGM on board can really help us, especially when they are, I don't want to say low cost because there is obviously a cost associated with them, but compared to some of these huge brand name medications, they are relatively much more feasible, I guess, for like the patient to utilize. And we are able to see a much bigger benefit. I've had patients decrease their insulin dose because they were just like eating so much better, and they didn't need to give themselves as much to counteract what they ate. So it's just another tool, and I think it could be a tool that could be really beneficial for a lot of patients.
Let's see. One thing I do need to start doing is logging in my meals and exercise. So I'm going to start doing that. And maybe we'll do a sequel to this video.
Yeah.
So we can come back here and see how that changes your view of what you can see. But keep on going to a couple of other of the pages of this tool
Okay.
before we wrap this particular episode up.
Perfect. Let's see. Let's go to the mealtime ones. So this is more like the mealtime pattern. So this is more like when our patients are logging. So that will be part 2. But then this will show us just like a weekly summary. So kind of just like goes more in depth, like what we saw like above, but just like day by day. So like showing us like when the highs are for our patients. And then so like on this like trend, like we can see like in the evenings it was like obviously a little higher than in the morning. So when you were fasting, it was not getting as high as in the evenings, obviously when you were eating, which is to be expected. And then the device details, like this is just showing me essentially like which kind of like software you're using. So like if if our patients are using a reader, it just like shows us that reader information. And then if it also shows like you switch to the Freestyle 3. So that is what it has like most recently logged. And then like some of our patients need more help managing their alarms than Christy does. So we make sure that like their alarms are on to make sure like if they are going too high or too low, we can see like where their alarm settings are at. And then this is just like more of like a visual of like the averages that we have at the bottom of this device. And so like this was just the last 2 weeks, but you can go 2 weeks, 4 weeks, 60 days, 90 days, like you can go back pretty far. And you can do the same thing on the Dexcom Clarity as well, like with that device. So it's all very customizable to see like which ranges we want to look at and all that kind of stuff.
Yeah, I will say that before I started intermittent fasting, a little over a year ago, I was using about 50 units of Lantus at night plus the metformin. And when I started seeing some results from the intermittent fasting starting last summer, today I'm consistently only using about 30 units. So I think that all this data is so eye-opening. And it certainly has the potential for big cost savings in your drug spend, and not only at the patient level but on the group level. So I think we'll wrap up this particular episode and just say stay tuned for another one soon where we can get a little deeper into like plan cost savings and employee out-of-pocket savings. So thank you, Madeline, for showing us your view of a great tool that I really believe employers should allocate some money for, to use, help employees have their eyes opened for the better when it comes to managing type 2 diabetes. So thanks again. I appreciate your time.
Well, thank you. Thanks for letting me share. This is something I'm really passionate about. I think it's a great tool for our patients. So I appreciate it.
All right. See you again soon.
Thanks so much.